Okay, once we have the plaque, what's best case scenario?
This is debatable. The recent literature has discussed plaque regression, meaning the ability to actually begin to take some of the fatty molecules out of the plaque and shrink the size of the plaque. Ultimately, plaque is really not the enemy. The enemy is plaque rupture events that lead to heart attack, stroke, and limb loss. And plaque by itself is the best proxy we have to understand whether plaque rupture is going to happen. But there are many, many, many people who will go their whole lives with some stable plaque in their arteries that never causes an issue. So again, we started out with, well, what's your blood pressure and what's your cholesterol? Now we're into this era where we understand that imaging is very helpful, and imaging shows us plaque, and that is the next best thing we have to understanding your risk for an event. But the event is actually the enemy. The plaque itself comes in lots of different forms, right? We have unstable plaque, we have stable plaque, and it does two different things. Eventually, you can have so much plaque burden, just actual physical amounts of it, that it can narrow the artery and you can prevent oxygen from being delivered. If that happens slowly over time, that tends to cause stable symptoms like angina, which is chest pain with activity. But some people get it when they, walk 3 miles, but at 2 miles, they're fine. And at 3 miles, they start to get this chest pressure. If they slow down or stop, it gets better. People can have the same issue in the vessels in the legs. It's called claudication. We walk for a while. The leg muscles start to cramp as they're needing more oxygen than they're getting. But if we stop and rest, it gets better. So that is typically a physical problem, just delivering the amount of oxygen that the body's asking for. The other thing that can happen is that we get a sudden blockage, occlusion, rupture of this plaque that then suddenly blocks off flow. That is most of the time what is causing heart attack, stroke, or sudden acute limb problems. And that is really the enemy here. So that's a soft plaque problem most of the time. And that means that plaque itself could go away. That's probably the best case scenario, and in some studies, we're having early signals that perhaps plaque regression is actually better than just stabilizing our plaque, the existing stuff that we have, and turning it from the vulnerable soft plaque into the hard, stable, calcified plaque. But up until now, in the kind of mainstream community, the idea has been, let's at the very least, just stabilize the existing plaque we have, turn it into this calcified, dormant volcano, right? And prevent it from becoming an erupting volcano. Let's just cool it down, stabilize it. And if that never changes, then we'll call that a win. And let's do everything we can to prevent the formation of new plaque over time.
Okay, coming back to our story there, where all the cells come in, we have inflammation in the vessel. Is that soft plaque at that time? And then if we don't get a rupture, and that eventually progresses over time, does that solidify and become the hard plaque?
Yes, to the best of our understanding, that is the progression. And so the plaque, different types of plaque are actually different time points of plaque evolution. And so there are many people who will have like a high calcium score, but if you do a CT angiogram, they actually have minimal soft plaque, either because they have changed everything in their metabolic health milieu that has now evolved and created a stable situation and they've put that fire out, or because they have undergone significant treatment for whatever inherited pathology they may have. And so we can have a fair amount of stable plaque that doesn't really cause trouble. Conversely, you can have people that have not too much calcified plaque, but a lot of soft, new atheroma or plaque. And that is that situation where, people are saying, I had a calcium score of 0, but then I had a heart attack. Or people saying, I had a normal stress test and then I had a heart attack. And so those are situations in which there's a fair amount of vulnerable plaque that may not be blocking blood flow very much yet, but is still very likely to create an event. And our understanding of how to capture those people early is a challenge, because it's not the majority of the population, but for those particular people, it is, of course, life-changing if this happens. So we're still evolving, because over-treatment is probably is definitely a concern, as well as under detection and under treatment.
Do we have any idea at this point if somebody has soft plaque, it doesn't rupture, eventually becomes the stiffened calcified plaque, what that timeline is to go through the process?
I think that the timeline really depends on how aggressive we are in terms of the environment in which things are progressing. So I have used the analogy of weather in a forest before, right? So a forest fire is this unstable plaque situation, and whether things continue to smolder in the long run versus totally extinguish has a lot to do with how dry is the environment. Is there rain? Is there lush vegetation? Or is this all dry tinderbox? And is that ongoing? So I think for people who have some soft plaque and then radically change what they're doing based on that information, or based on any kind of impetus to have a new health journey, then that calcification can happen more rapidly. Certainly, we know that certain medications can rapidly stabilize plaque, but I think it's still on a time frame of months to years. We're not talking about days to weeks.
Okay, got it. But living the lifestyle and adopting the diet we're going to talk about later will speed up that process of getting from A to B.
I believe so.
Let's come back to our soft plaque, unstable. Do we know when there's an event and that ruptures, what makes somebody's plaque more vulnerable to that?
The amount of lipid inside the plaque tends to be relevant, and that we know from prior imaging studies. There is a cap over top of the plaque. You can think of this like the little bit of earth or crust over the top of a volcano before it erupts, and the thickness of that fibrous cap is directly relevant to plaque rupture risk. So the thinner the cap, obviously the more likely you are to have an event. And we know that certain things kind of trigger events. So heart attacks are more common around like daylight savings time changes. When we have a disruption in the circadian rhythm, it's more common around the holidays when people are more stressed out or potentially like feeling more socially isolated. And, all kinds of stressful things can trigger this. But I would say spikes in inflammation can absolutely cause a rupture event. Anything that is acutely stressful may trigger that. We don't know for sure what triggers it in any particular person at any given time, but certainly at the population level, we have some indication that acute stressors can do it.
As somebody moves towards that solidification of the plaque, it's now calcified. Are you concerned of an event at that point? Or is that person basically the same as somebody without plaque once that's totally solidified?
Based on the population data, they are never the same as somebody who has no plaque. But I think for example, the literature in endurance athletes is interesting, right? We have evidence that suggests that endurance athletes have more calcification in their coronary arteries than you might expect. And for the same level of calcium, if you compare an endurance athlete to the average sedentary person at the same calcium score, call it 300, the endurance athlete is much less likely to have an event, but they don't go all the way down to zero. Their risk doesn't translate to somebody with no plaque or a CAC of 0, but it's much less than the same CAC of 300 in a sedentary person. So for whatever reason, whether that is that there is still some ongoing other plaque that we haven't detected, whether that is embolization from the calcified plaque, or I don't know exactly. What I can say is your event risk comes way down. We're probably never going to get it to the level where it's 0 or no risk or the same as somebody with a CAC of 0, but it's much better.
Okay. As somebody is going through the healing process, they're going from a state of a lot of soft plaque to hard plaque. I would assume their calcium score will go up. Does that happen? And then how do you reassure somebody that they're on the right path if that's happening?
This is why I don't love repeat calcium scores by themselves, because you can have this in one of two scenarios. The first scenario where your calcium score goes up is that we are transforming soft vulnerable plaque into the calcified, more stable plaque. And that's a good thing, right? Overall, the total plaque burden is the same, but more of it is stable and calcified. The alternative situation, which you cannot really distinguish between these if all you're doing is calcium scoring, is you have progression of disease. Whatever we have done in terms of your nutrition, your lifestyle, medications and supplements, sleep and stress, whatever we've done to intervene is not enough, and the calcium score goes up. Well, that in a person where we're not doing enough is actually the progression of disease. They have more calcified plaque and more soft plaque, but a calcium score doesn't tell you that. So what you need at that point is more advanced imaging, either a CCTA, that coronary angiography with dye, or a CIMT that will talk to you about how much soft plaque there might be and how much inflammation there is in the vessel wall. Both of these are in this scenario that I'm discussing, both of these are sort of being used beyond where they've been tested, right? There's not a guideline that says if there's progression in your IMT or there's progression in your soft plaque volume that we're going to do something differently. But intuitively, it makes perfect sense, right? If there's more soft plaque or total plaque volume, then obviously we're not doing well enough controlling the environment around this forest fire. We have not put out the fire. So for this reason, I don't really recommend repeat calcium scans by themselves to help us understand what's happening, because it's one of two things. One's good, one's bad. And the real way to get a better handle on that is to get more advanced imaging.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
I, as a vascular surgeon, predominantly see people who've had a problem already from plaque. Why do you have plaque? Is this an inflammation problem? Is this a lipid problem, an insulin problem?